Female reproductive system is more complicated than the male reproductive system, but they are both the same in that we're talking about exocrine and endocrine glands. The ovaries, like the testes, are both. They are a mixed gland. They are producing hormones, specifically estrogen, progesterone, and a little bit of testosterone. And they are also making a secretion that will exit the body eventually in some form. And that would be the oocyte or the gamete. The purpose of the uterus is merely to provide support for the developing embryo/fetus. And that uterus also is going to undergo changes according to the menstrual cycle. So we're going to learn about two cycles today, the ovarian cycle and the uterine cycle. And then for you, on your last exam, you should be ready to talk about both and how they overlap. The ovaries are the primary sex organs. Everything else, remember, is accessory. They are roughly almond-shaped, and feel free to keep getting up and graze, because I'm not taking this stuff home. They are held in place by something called the ovarian ligament, shown right here. So that's attached to the side of the uterus. And also, they're held by something called the suspensory ligament, which is really a misnomer. It's not a ligament at all. It is the ovarian arteries and veins wrapped around with the mesentery. The gonadal arteries, as you learned from them on the cat, are the ovarian arteries if it was a female cat, and it would have been the testicular arteries if we were studying a male cat. The ovary has a cortex and a medulla. And we see here the ovarian artery and vein entering and delivering nutrients or picking up waste products. For the artery, delivering nutrients, vein picking up waste products. Enters into the medulla, and around the cortex, we see the following structures. We see developing follicles, and within them, developing oocytes. We need to talk about a follicle versus an oocyte and what they look like as they mature. So this picture is showing you the progression of follicles maturing and then finally an oocyte being released. And the remaining follicular cells are going to be the corpus luteum. Have you seen the model of the artery in lab? Yes? Yeah. I always pick it up and say it's not a boob. But a lot of students think it's a boob because from the side you can see the oocyte being ovulated and it looks like a nipple. I can't tell you how many people have said, is this a breast? No, not at all. It's an ovary. Just like with the testes, we see an outer white layer, the tunica albuginea, a hilus, where we have blood vessels and nerves and lymphatic vessels entering or exiting. And the follicles, like I said, are going to be these cells surrounding the oocyte. The oocyte is the gamete. The follicles are support cells that will help the oocyte start to mature. Ladies, you are born with every single oocyte you will ever have. They were made before you were born, and they are arrested in prophase 1. As you ovulate, then you ovulate a secondary oocyte, which I will highlight. And the secondary oocyte is still not an egg. We don't call it an egg. A lot of people do. It is actually a secondary oocyte, and it's arrested in meiosis II, specifically metaphase. It won't finish unless it's fertilized. So the ovarian cycle has 3 phases. Again, 2 cycles that we're going to learn today, ovarian and uterine. You should know each one, but also relate how they're overlapped. And there's a slide that I'll show you where you can see both overlap. Ovarian cycle has a follicular phase, ovulation phase, and a luteal phase. The follicular phase is where several follicles begin to mature. And as they grow and mature, this is under the direction of FSH, which comes from the anterior pituitary. It stands for follicular stimulating hormone. And also LH, which will cause the follicles to actually make estrogen and progesterone. That lasts about 14 days. Ovulation is basically a couple of days, if that. We can actually monitor the surge of LH, so when it peaks, we know that that is going to lead to ovulation. Once the oocyte is released by the ovaries, the uterine tubes have fimbriae and they will sweep the oocyte into the tube. The cells that were part of the follicle that remain behind, like the theca folliculi cells and the other follicular cells, their job is to release hormones, primarily estrogen, but also progesterone. They are the structure that we call the corpus luteum. Eventually, the corpus luteum will die and become scar tissue, and that's called the corpus albicans. Al means white, so it looks white when you look at it. And here we have a primordial follicle. This is what we're born with, ladies. Inside is an oocyte, a primary oocyte, which is arrested in meiosis 1, specifically in prophase 1. When we start to enter puberty, many follicles will begin to mature. As they mature, they get more and more of these surrounding support cells called granulosa cells. And around them is another set of cells called theca folliculi cells. And theca folliculi cells have muscle-like properties, but they are not muscle. But they can when by muscle-like properties, they can, it's not contraction, it's not muscle contraction, but they can change their cell size, and when they do this, they basically can pinch, like you're pinching a zit. They can pop the follicle and lead to the release of the oocyte. These granulosa cells are responding to follicular stimulating hormone. Eventually, in the middle, we start to see a fluid-filled space called an antrum. There are some granulosa cells that are associated around the primary oocyte. And this in blue is showing you the zona pellucida, or as I like to say, the hard candy shell. It is made of polysaccharides, so those are sugars. Eventually, this follicle, which at this point, once you see the antrum, it's called a secondary follicle. When you start to see more than one layer of granulosa cells, it's called a primary follicle. When you see a very large antrum and these granulosa cells that are around the oocyte called the corona radiata, which means a crown that's radiating around the oocyte. This is called a mature follicle, also known as a Graafian follicle. Many follicles can begin to mature, but only one will release the oocyte. The oocyte technically finishes meiosis 1 just before ovulation, just before. When it is ovulated, it is a secondary oocyte, and it's arrested in meiosis 2, specifically in metaphase 2. The theca folliculi cells, like I said, have the ability to change their cell size and shape, and this helps pinch out the oocyte. It was actually caught on video. Someone was having surgery near her uterus, and physicians were recording the surgery for teaching purposes, and they happened to catch on video her ovary ovulating while they were working somewhere else nearby. And it basically looks like a large fluid-filled zit, and when it pops, it's not that it squirts out, it just kind of oozes out. It's really interesting to see that. The granulosa cells continue to produce estrogen and progesterone. Their job is to sustain the pregnancy should one occur, and that is the corpus luteum. And then if there is no pregnancy, eventually it will be replaced by connective tissue, scar tissue, and it's called corpus albicans. I asked you to review your meiosis. There are questions on your exam that asks you to identify, either for sperm development or oocyte development, which cells are diploid and which ones are haploid. So please know the progression of the cells. Again, the oogonia, the stem cells, they are diploid, as you can see up here, and they replicate and they divide. Just like we saw with sperm, a primary spermatocyte or a primary oocyte, they are entering meiosis 1. Ladies, when you were born, all of your primary oocytes still were 2N, diploid. They were rested in prophase 1. When you entered puberty and you started to ovulate, many of your follicles, your primordial follicles, turned into primary follicles. Then they started to develop an antrum, and then they were called secondary follicles, which is not shown on this slide, but it was on the previous. When we see a mature antrum in the corona radiata around this follicle, that's called a Graafian follicle. And then we have a secondary oocyte that's ovulated, but it is arrested in metaphase 2. Meiosis 2 will be completed only if there is fertilization, which is actually very precarious. That's the reason why, ladies, if you wait until much later in life to have or start a family, your oocytes are as old as you are, even older, because they were made before you were born. And a lot can go wrong in this second cell division. And if there isn't perfect separation of those sister chromatids, it is a process called non-disjunction, and it could lead to trisomies or monosomies. The most common trisomy is Down syndrome, trisomy 21. After age 35, you are considered by most states to be in advanced maternal age. There is a 1 in 200 chance that you will have a child with Down syndrome. And after age 35, with every 5 years, the chances increase. So it's nothing to be taken lightly. Also, once you're age 35, insurance companies are required to offer you testing that the insurance company must cover. That testing is up to you whether or not you choose to do it, and it is either chorionic villi sampling or an amniocentesis. Basically, they're getting a sample of fetal-derived tissues to find out if the fetus has a trisomy or a monosomy. The idea is to educate you about what to expect. What you decide to do with that information is up to you. Again, you don't have to have the testing done if you don't want it. All I'm saying is after age 35, insurance companies are obligated to offer the tests and they pay for them. If you want them done before your advanced maternal age, typically you're going to have to pay for those to some extent. All of the daughter cells that are, yes, Josh.
Those tests are kind of dangerous though, right? Like, because you know you have to put a needle through them.
They have risks. Every procedure has a risk. Having a spontaneous abortion from having an amniocentesis has the same odds, 1 in 200. Chorionic villi sampling is done earlier. It also has risks, and yes, you can lose the baby.
Yeah, because my mom was 37 when she had me, I think, and then every day I'm telling her that she'd do it, she refused to do it because she was like, it's not worth the risk.
It was equal risk.
Yeah.
It was equal risk. Sadly, my aunt was pregnant with a baby boy, and early on she had CVS done, found out it was a perfectly healthy baby boy, and late in her second trimester she spontaneously aborted. It was super sad. Like, she was well along. Very sad. That's where you have to weigh the pros and cons. Are you the kind of person where you want to know what to expect? You need to make a decision what to do with that information. Some people want to know, even if it's bad news, so they can prepare their home for a child with special needs, prepare older siblings, if that's what it takes. So they want to be prepared. Other people just don't want to know. That's fine. I'm just telling you what is offered. I'm not telling you what decisions to make at all. When the cells are going through this division, unlike with spermatogenesis, in spermatogenesis there are 4 daughter cells that are made. In oogenesis, we only have 1 true ovum that will be made when there is fertilization. All the other 3 are called polar bodies, and they do not have enough cytoplasm to sustain life, even if they were fertilized, for the most part. I'll get back to that real soon. The sperm, if you look back at spermiogenesis, when they change their shape, they shed a lot of their cytoplasm, they lose a lot of their organelles. They have mitochondria, but that's mostly to propel the flagellum to let them swim. So the mitochondria don't actually, for the most part, enter the oocyte at fertilization. So the oocyte has to provide all of the organelles. That's part of the reason why we can trace our ancestry based on mitochondrial DNA, because you inherit that from your mom. So we can trace it all the way back. These polar bodies, though, as you get older, this particular polar body, once the oocyte, the secondary oocyte, is ovulated, this polar body could have enough cytoplasm. So as we get older, ladies, that polar body could actually get big enough where it could be fertilized, and you could have twins, and they would be hemi-identical, half identical. Isn't that weird? Half identical. Okay, so, and if you do not have fertilization, then ladies, you do not have an egg that comes out with your menstrual flow. It is still a secondary oocyte. It is not called an egg until it finishes meiosis II, which means it has to be fertilized. Then it's called an egg/ovum. Once the 2 nuclei merge, then it is a single cell new organism called a zygote. Uterine tubes, also known as fallopian tubes, they have, do you remember the parts out here, the fimbriae, the little fingers? Infundibulum means that it's a trumpet shape. And then we have the oocyte going up here through the fimbriae. They sweep it in to the infundibula. And the ampulla is this part right here. And that's where fertilization typically takes place. Then there's a narrow region called the isthmus. And then finally we get to the uterine cavity. There is a fundus of the uterus, the body. We have the cervical canal. There's an internal opening into the cervical canal called the cervical os, internal cervical os, and an external cervical os. I'll talk about these. I'm sure you've already talked about the layers of the uterus in lab, because I'm sure you have. They will be tagged, so be ready for that. Make sure you know which layer is the myometrium versus endometrium versus periometrium. The uterus is not erect. It is anteverted, which means it flops forward. The body of the uterus rests on the woman's bladder. It's like a pillow. And the uterine tubes reach around like this. And if I had another pair of arms coming off the side of my body, my forearms would represent the ovarian ligament, and my hands would represent the ovary. So the uterine tubes reach around like this, and the fimbriae are going to sweep the oocyte into the infundibulum. Pouches. There are, when the uterus flops forward like this, there's something called the broad ligament. And the broad ligament can I use you as a demonstration? Mm-hmm. Stand over here. I won't record you. Pretend you're a uterus. There you go. Good job. Okay, so the broad ligament is basically mesentery, not mesentery, sorry. The peritoneum that's going around the uterus, and if it's around the uterus itself, it's called the mesometrium. If it goes around the uterine tubes, it's called the mesosalpinx. And then if I could be the ovary with the ovarian ligament, the part of the peritoneum that goes around the ovary and the ovarian ligament, thank you, is called the mesoovarium. Okay, so there is a round ligament that is a continuation here. So here we see the ovarian ligament, and there's a continuation of the round ligament. It's going to exit the woman's body through the inguinal canal, and it attaches into an external feature called the labia majora. It's weird, ladies, to think that your ovary is somehow connected to your big lips outside, but it is. Oh, I didn't tell you about pouches, we still need to do that. So remember that my jacket around Sierra, and it went around her head and her body. When the uterus is covered with not the mesentery, you want to keep saying that, but the peritoneum, when it flops forward, there is a pouch in between the uterus and the bladder, and that's called the vesico-uterine pouch. There's also a pouch behind the uterus in front of the rectum, and that's called the recto-uterine pouch. I'm going to back up and show you a picture of that. I had it on the previous slide. So right here, this pouch is the recto-uterine pouch, and this pouch right here is the vesico-uterine pouch. They are clinically important to us, especially if you think about someone who has an infection inside the peritoneal cavity. That's called pelvic inflammatory disease. Women are more likely to be afflicted with that than men because our genitalia is so close to the external environment, it's easy for infections to go up through the vagina, through the uterus, out the uterine tubes, and into the peritoneal cavity. A lot of fluid can accumulate in the peritoneal cavity during a pelvic inflammatory disease, and the fluid is very heavy and can put pressure on nerves that are in the pelvic bowl. When that happens, the woman will definitely be she's going to go to the emergency room in one way or the other. And when she comes in, you'll know something's not right because she'll be walking in shuffling because it hurts so much to move. We call that the PID shuffle. She will not be waiting long in the emergency room. She is going to be met with someone who has a wheelchair, and they're going to take her away to do emergency imaging to see if it's an ectopic pregnancy versus pelvic inflammatory disease. Both can be very lethal. They got to take care of it right away. All of this fluid typically is going to accumulate in the recto-uterine pouch. And if they want to aspirate out some of the fluid, they can insert a needle through the vagina and break through the back wall to the recto-uterine pouch and actually drain that fluid. it's very painful to have the fluid in the first place, so pain is relative. Now we're going to get into the uterine cycle. The uterine wall, we have the perimetrium, which is the visceral peritoneum. That's part of the broad ligament that I showed you wrapping my jacket around Sierra. The myometrium is smooth muscle that's important for orgasm as well as labor before delivery of the fetus. The endometrium is going to be composed of 2 layers. The stratum basalis is not the part that's shed every month, ladies. The stratum functionalis. So think of it as the functional layer that you shed. The stratum basalis, its job is to replace with cell division the stratum functionalis after your menstrual cycle. So up here, you're seeing arteries, like the uterine artery, leading to an arcuate artery. Do not memorize this. I do not have this on the test. Leading to radial arteries, and then we get these spiral or coiled arteries. And basically, it's this outer layer that's going to be shed, and these blood vessels start to die. They become necrotic, and as they die and they recoil back and bleb off, that's when the bleeding starts. So we have 3 phases to the uterine cycle. That's good because that's easier to remember. So did the ovarian cycle. It also had 3 phases. The uterine cycle has the menstrual phase. That marks the beginning. Those are typically days 1 through 5. However, that's variable for women everywhere. I just want to know, who has a menstrual cycle of 1 day? Who has her period for 1 day? Out of almost the 15 years I've been here, I've had one student go, me, no, it's only 1 day. It's not even a whole day. I said, what the hell? Do you just sneeze and it's over? What is that? And then some women, it's like 10 days, it seems like. So the average is around 5. That's also variable. Some months, ladies, as you well know, are worse than others. After the menstrual phase, we have to build back up the uterine lining. The stratum functionalis is rebuilt. That's called the proliferative phase. And then the secretory phase is the last part of your menstrual cycle, which is where the uterus is preparing for implantation of an embryo. So secretory phase, meaning we're having release of nutrients, for example, to sustain the pregnancy until an umbilical cord and placenta are grown from the embryo. So here is our menstrual cycle and ovarian cycle overlapped. Menstrual cycle is part of the uterine cycle. So here's our days 1 through 5. During this time, we would have primary follicles starting to morph into secondary. So the ovary would be in the follicular phase. Then as the uterus morphs into the proliferative phase, this also overlaps still the follicular phase of the ovary. At day 14, we have a secondary oocyte that's ovulated. And this marks the beginning of the secretory phase for the uterus, which is preparing for implantation. And then the corpus luteum is responsible for generating estrogen and progesterone to sustain a pregnancy until the placenta is in place. The vagina has 3 layers. It has an outer layer, the adventitia. It has a mucosa that have macroscopic folds, rugae. Hey, name all the places where you have rugae. Stomach. Vagina. Ribbed for his pleasure, as I like to say.
What does that mean?
What do you mean?
No.
What does that mean?
What do you mean, what does that mean? There is an opening called the vaginal orifice, and then the fornix, there are two fornices. Can't see it quite well with this picture, so I'm going to back up a few pictures to show you the two fornices. They are important if you are wearing a cervical cap as a form of birth control. So there's an anterior fornix right here and a posterior fornix. And if you ever wear a cervical cap, if you do, you have to insert it through the vagina and actually put it on the cervix. These fornices have to be measured for a good fit for the cervical cap. So ladies, it's not like you could just take it out, wash it off, and pass it off to somebody else to use. It is fit for you, which is, it's disgusting anyway to think that you would even do that, but anyway, so it has to be a good fit. Huh?
They put like a mold in there or something?
A mold?
I don't know, how do you figure out what size it's supposed to be? But how do you like, so somebody else has to do it obviously then.
So when you have your well woman exam, they have this archaic device called a speculum that goes in, and then they open it, which makes your vagina go so we can see right in there, and it's not hard to take a device that actually can measure these things. I'm just telling you. Yes.
That's what they do for a top smear, right?
What, use the speculum?
Yeah.
Yes. That's what they do, and then they go in and scrape off some cells.
Yeah.
Because that feels good. It's great to be a woman. Well, bad timing because you're eating. But this is the external genitalia. There are some landmarks, for lack of a better word, for men and women. If they're laying down in this position, we look at this triangle type appearance, and that helps us locate certain landmarks. So these would be where the ischial tuberosities would be found, then the rectum, and then up here is the mons pubis. Ladies, you have two lips. You have labia majora and labia minora. The labia minora, within them is the vestibule, which is appropriately termed the waiting place. And they will wait until we say, okay, right? Dana's like, maybe. Maybe. There are some glands that have opening vestibular glands, and those are releasing some secretions to keep that area lubricated. We have the urethral opening, we have the clitoris, we have the clitoral hood, which is the equivalent of the prepuce on the man's penis. What else do I want to say about that? This part where the labia minora merge, that's called the fourchette. And if a woman is actually birthing a baby and her vaginal orifice can't expand well enough, they will do an episiotomy. They will basically cut towards the anus. And a lot of women don't want an episiotomy, and I get that. But understand something, if you are birthing a child with a head circumference in the 90th percentile or larger, you can tear. So what would you rather do? Rip down to your anus, or have a cut, which is easier to sew and heal from? Yes.
If they don't, is it like they're risk of hemorrhage?
No, if they don't cut you and you tear, that is a very long time to heal. They will do their best to stitch you up, But stitching torn edges, have you ever, I was gonna make a joke. I was to say, have you ever menstruated?
Straight in. Oh, I got it.
Mend something in a straight line? Menstruate. It's a lot easier to mend something in a straight line versus a jagged tear through cloth. Same thing for your body tissues too. So if you tear, understand, you can rip all the way down to your anus.
So they do it before they know how big the head is, they just do it just in case.
Nowadays with ultrasound, they can get an idea of how big your baby's head is, and they also can see your pelvic bowl outlet and basically gauge if you have enough room or not to birth the baby. What do you mean, why do they do that?
Have babies in
As if they know that you're going to have a baby with a large head, they will give the job to whoever is with you in the room to birth the baby. Patrick's like, not me. Tap out! Said who's ever with you. So pick wisely, but they might have to massage you, which is basically where someone is putting their fingers into your vagina, ladies, and starting to do this back and forth, trying to open you up. And eventually the idea is that the whole hand is in there, opening you up. You're never what? You're never gonna.
No.
Then I consider my job complete. Hire someone.
That's what I'm saying, I'm Kim Kardashian.
Hire someone. That's the way to go. So, ladies, our clitoris is a homologue to a man's penis. It does have erectile swell bodies. Our clitoris does get engorged with blood upon sexual arousal. All of us ladies have a different sized clitoris. Some of us are showers versus growers, as I alluded to towards the men on Tuesday. Some women have such a large clitoris that when it's engorged, it can look like a very small penis, which can be very offsetting. Which can be very offsetting, apparently, to the partner that she might be with. Like, what are you? Any questions?
Story time? We're all very curious.
Okay, let me see. What are some stories I have heard?